Good evening, students. Today we'll be discussing about applied neuroanatomy and EMG. And last few classes, two classes we had on neuroelectrophysiology. Initially, we discussed about the potentials, the electrodes, and attachments, and things like that. And then last class we discussed about neuroconduction studies, and few things are left, which I thought we should now deal with them. So first, let us start with volume conduction. Volume conduction is the basic of neuroelectrophysiology. It is a process in which an intracellular potential travels through extracellular tissues, and it is termed volume conduction. The compound muscle action potentials, sensory nerve action potentials, they all result from extracellular recording of intracellular events. That means there is a potential that is conducted. The volume conduction occurs as the impulse travels from the stimulator through the extracellular tissue to the stimulated nerve. The stimulator produces a potential which travels down the nerve to the muscle in which an action potential is generated, and which is in turn picked up by the electrodes placed over the muscle belly. So that is in short what is the volume conduction. This is essential for neuroconduction studies. And if you have excessive volume conduction and it produces inaccurate waveforms, suppose if a high intensity stimulus is applied, excess volume conduction occurs and multiple nerves will be, peripheral or cranial nerves will be stimulated, and a composite erroneous waveform results. So there are near field potentials and far field potentials and even potentials. So near field potential is a volume conducted potential that is recorded close to its source, and it is termed a near field potential. The compound muscle action potentials, which we dealt in the last class, sensory nerve action potentials, and motor unit action potentials are all near field potentials. The MUAPs, which we are going to study in detail this time. Far field is as a recording device is moved away from the stimulator, the source, the amplitude is decreased and the latency is prolonged. Examples are somatosensory evoked responses, and far field potentials by definition do not change significantly in latency or amplitude with distance from the source. So these are constant phenomena. So these are far field potentials. Example is somatosensory evoked responses. You can see the ulnar motor supramaximal stimulation results in excitation of only one ulnar nerve. This is called normal morphology of the CMAP of ulnar, and it has got a normal onset latency. Similarly, the median nerve has a supramaximal stimulation results in an excitation of the only median nerve, and this is probably prolonged and could be in CTS, carpal tunnel syndrome. And suppose if a higher supramaximal results in co-stimulation of the ulnar nerve with median nerve, this will be like this, and significantly altered CMAP morphology with the long duration. So the potential should be, the current which you apply to the stimulating electrode should be low, and slowly, gradually you increase. And after you reach the maximum amplitude, then you increase by another 20%. After that, don't increase anymore. That's a theory. Now, let's look at the spinal cord anatomy, because these are basics for which we're going to use in our EMG techniques. And so before we dwell on to the EMG technique, let me go through the anatomy of the spinal cord. And most of the students have problem in answering this question, how the brachial plexus is formed. So let's start the ventral roots and things like that. But exactly it is the ventral root and the dorsal root, they join to form the spinal nerve, which again divides into ventral ramus and dorsal ramus. And these ventral rami, they join to form the brachial plexus, and the dorsal ramus goes and this supplies the paraspinal muscles. And here you can see the dorsal root ganglion. So if a pathology is before this, the snaps will be preserved. If a pathology is after this, then the snaps will be absent. And that's the point which last time we highlighted. And if you do an EMG of dorsal ramus and radiculopathies, that will be abnormal. So this part of the anatomy is very, very important. This is the this is the this is the ventral horn, and this is the posterior horn, the bell megendri. The bell megendri law says that this is purely motor efferent and this is sensory afferent. So this is about sensory nerves efferents and motor afferents are like this. This is the anterior horn cell which is depicted here. This is central canal of the gray matter in the spinal cord. So if you look at the most of the orthopedicians and neurologists, neurosurgeons are interested in the herniated discs and narrow roots, which you can see there is a lateral L4-5 disc herniation here. You can see the disc herniation, which is pressing on the nerve and causing the neurologic pain. Here there is a central disc herniation. There is a central disc herniation. And you can see the central disc herniation. So this central disc herniation also causes pain, but here the SLR is not the only thing. You have to lift both the limbs up, and if they are not able to do that, you should suspect central nerve. So this is the basics of herniated discs in the lower limbs. Now you can see this is L4, L5 disc, and you can see the disc that is pressing on the nerve root here, which is coming from this spinal cord here, and this is the thing which is pressing on the nerve root. So you can have the root pressure, or it can be at the spinal cord, and the root origin also can be pressed. This is the L5 root and the L4 root. Similarly, you have the cervical vertebral body, and this is the dorsal, these are ventral roots, and these are coming out, and this is the cervical narrow root that is coming out, and anything can that will be a pressure here if there is a center the disc prolapse. So after seeing that, then we should know what are the muscles that are important for us to do in EMG and to identify the root and the nerve. So in upper limbs, we should always remember the brachioradialis, which is a radial innervated muscle, C5, C6. Extensor indicis proprius, that is radial, C7, C8, the same nerve but different roots. And gluteus medius is L5, S1, that is the inferior, the superior gluteal nerve, which is the root collateral nerve. And semitendinosus, semimembranosus, tibial branch of the sciatic, that is L5, S1, different nerves but different same nerve root. Here this is different roots but the same nerve. Short head of biceps femoris, common fibular nerve L5, S1, and long head of biceps femoris, tibial branch of the sciatic L5, S1. So this is the same root and different nerves, and the muscles are almost close. So we should know the clear-cut anatomy and the muscle distribution of the upper and lower limbs to perfect this art of EMG. And what are the important muscles you should know? That is deltoid, which is innervated by axillary, C5, C6, biceps, musculocutaneous, C5, C6, radial, triceps, C7, C8, T1, pronator teres, median, C6, C7. This is one of the median muscles that is innervated by C7 root. Abductor pollicis brevis, that is median, this is T1, mostly. First dorsal interosseous ulnar, C8. The lumbosacral, similarly, these are the muscles which we target in the upper limb and study various roots, C4, C6, C7, C8, T1. And the lumbosacral median femoral tibialis anterior, that is L4 usually, or the common peroneal nerve, and L5S1, tibialis posterior, and tibial nerve L5. So these are the muscles which are in the lower limb. I'm asked what are the median muscles which are important. All muscles except these two in the forearm, that is flexor carpi ulnar and the ulnar nerve. So flexor carpi ulnaris and medial half of the flexor distal profundus, and hand muscles. These are the lateral lumbricals, apponis pollicis, abductor pollicis brevis, flexor pollicis brevis, superficial head. These are all median innervated muscles which you should know. The ulnar muscles which are important, the flexor compartment of the forearm, except of this flexor carpi ulnaris, and medial half of the flexor digitorum profundus. These are the ulnar nerve muscles, and the loaf muscles, all intrinsic muscles except the loaf muscles which have said. These are the hypothenar muscles are included, opponents, flexor, abductor digiti minimi. The adductor pollicis is also ulnar innervated, and interossei, two medial lumbricals. These are all the ulnar muscles. So now the lower limb, let us see the anterior compartment. The obturator nerve should know the adductors of longus, magnus brevis, and gracilis, obturator externus. But we usually don't touch these muscles for EMG. But here we may do vastus medialis and vastus lateralis at time for femoral nerve, and gluteus medius and minimus, superior gluteal nerve, and inferior gluteal nerve, gluteus maximus. Then you have the this radial muscles which should have come earlier. That is triceps brachioradialis, ischocarpus longus, brevis, ulnaris supinator, and the abductor pollicis longus. These are the muscles which we have to remember while doing EMG. The posterior aspect of the limb, that is tibialis portion of the sciatic nerve, semitendinosus, membranosus, long head of biceps femoris, gastrocnemius, soleus. We usually do these two muscles, flexor digitorum longus and hallucis longus, occasionally, and the abductor hallucis and other intrinsic muscles are rarely targeted. Here, short head of the biceps femoris, common fibular portion of sciatic nerve, if you suspect, and this is above knee, so we may have to do this. And tibialis anterior, we always do. Extensor digitorum brevis, we always do. These anatomies are very important for your surface anatomies of these two muscles. Extensor hallucis and peroneus tertius, we don't do usually. And the peroneus longus and brevis muscles also, we don't do those. So with this, we'll go to the sensory branches, and briefly we just touch upon them before we go to EMG. The palmar cutaneous branch of the median nerve, that before the carpal tunnel it originates, supplies sensation to the lateral palm of the hand. If you are asked what is the root, what is the correct place to test the sensation of the median nerve, you should say that it's the tip of the forefinger and the right. And because distal branches after carpal tunnel, they supply sensation to the palmar aspect and tips of the lateral 3.5 fingers. So the index finger tip is the spot which you should test for median nerve. And the upper limb, you can see that the digital, these are the ulnar nerve distribution, and this is the medial nerve distribution. And on the back side is superficial radial nerve point which you should test, and here is the ulnar nerve point which you should touch. And if there is a sensory loss on this medial antebrachial cutaneous nerve, that means you are dealing with a trunk problem, and roots, trunks, division, scars, and it's not only nerve problem. So if there is any sensory loss on this side, we should interpret that way. And the lateral antebrachial cutaneous nerve is on the lateral aspect. Similarly, this we have seen the dorsal aspect, and this is the point where you should look for the radial nerve innervation, and that's a sensory testing site for that. So the sensory branches of ulnar nerve, palmar ulnar cutaneous, supply sensation to the medial aspect of the palm. Dorsal ulnar cutaneous supplies sensation to the medial aspect of the median dorsum of the hand and posterior aspects of the medial 1.5 digits. The Guyan canal is often asked in exam. Distal branches supply sensation to the dorsal aspect and tips of the medial 1.5 digits. So this Guyan's canal anatomy is also very important for students. The sensory branches of ulnar nerve, posterior cutaneous nerve of the arm, which arises from the radial nerve in the axilla and innervates a small area on the lateral aspect of the shoulder, which is also incidentally C5 dermatome. Lower lateral cutaneous nerve of the arm arises from the radial nerve in the upper arm above the spiral groove. It supplies the lateral arm. It's a muscular cutaneous nerve branch also supplies this. The posterior cutaneous nerve of the forearm arises from the radial nerve in the upper arm above the spiral groove and supplies the lateral arm. Superficial radial nerve arises in the proximal forearm and supplies the skin of the dorsum of the hand and the lateral 3.5 fingers, which we usually test. So all these nerves, they originate mostly in the axilla and come down. This is a sensory distribution. This is a L4 dermatome, and that is a saphenous nerve distribution. The sural nerve distribution and superficial peroneal nerve distribution. Both the superficial peroneal and sural nerves are tested usually. So that brings us to the EMG technique, basic EMG technique. And see the needle EMG, and whenever we do needle EMG, there are some procedures which we should follow, what the precautions which we should take. It is a specific electrodiagnostic technique in which an electrode is used to visually and sonically display the electrical activity of muscle. So a needle electrode is inserted through the skin into the specific muscle to acquire and display muscular electrical activity, which is displayed as waveform on the screen. What is EMG needle? It's simply a tool to measure the electrical activity in the muscle. No electrical stimulation is used with EMG. Just the needle is sufficient. It picks up the electrical activity. And it evaluates 4 basic components of standard EMG, that is insertional activity, spontaneous activity, motor unit analysis, and recruitment for each muscle which you are going to do EMG. So these 4 terms will keep on coming in this lecture. So the checklist at the patient, when before you do EMG, what you should do: confirm the patient's identification and verify the indication for EMG. Suppose if you are doing it for polymyositis, then you have to concentrate on insertional activity. If your indication is for ruling out myopathy, then recruitment pattern, you should be concentrating whether there is a complete recruitment and the MUPs are small in size and polyphasia like that. If you are dealing with a neuropathic condition, then you should look for joint fasciculations and various insert and the spontaneous active potentials which you are going to study. So give a brief overview of the test to the patient and reassure the patient about minimizing discomfort. There will be discomfort, but we have to tell him that we are going to look into that, and ask about the possible contraindications and precautions such as anticoagulations. If they are using, then there will be a lot of bleeding, so you should stop before you plan your EMG. And the most important is verify the ground and the reference electrodes if they are in place. The muscle being examined should be relaxed and accessible to the examiner. And of course, there are universal precautions. The gloves should be observed. Avoid examining areas of skin compromise, open wounds, skin infections, significant areas of edema or lymphedema. Sometimes you are referred cases from the surgeons and orthopedic people for doing EMG in such situations, when you should politely refuse that we cannot do it. So that's at the patient level. And at the EMG machine level, confirm that the gain, the sweep speed, the filter settings are appropriate, which we're going to talk a bit in coming slides. And at the amplifier, verify the ground and reference electrodes are plugged into the amplifier and make sure the pre-amplifier is turned on. And the active electrode, the needle serves as the active electrode. When a monopolar needle electrode is being used, a reference electrode is necessary. The reference should be nearer the location of the needle insertion. If a concentric needle or a single fiber needle is used, a separate reference electrode is not necessary. But what we use is a monopolar needle always, and we require to use a reference electrode. So you have to reduce the anxiety and discomfort of the patient, because there is pain. Pain is common if the needle is in the muscle. Actually, when you pierce the skin, there will be pain, but in the muscle, usually it is painless, except when it is near to the end plate region. So whenever in the muscle, if pain is felt, you have to withdraw the needle and place it somewhat differently away from the end plate region. When this is apparent, the presence of end plate noise, the spikes, which I'm going to show you, quickly reposition the needle away from that area. And you have to provide comfort and continued verbal sympathy with the patient throughout the study. Keep talking to him. Reassure the patient that any discomfort associated with the EMG is not long lasting, it is temporary, and they should bear with the test. Insert the needle through the skin quickly, but move the needle within the muscle gently and slowly. So when you push into the skin, you do it quickly, because that's the painful part. Once the needle is in the muscle, the pain is not very much. So avoid hyperventilation. Change needles if there is increased resistance or excessive pain associated with the needle movement. Especially anxious patients, begin with the most important muscle to minimize the number of needle insertions. Paraspinal muscles in suspected radiculopathy is important for us. If they are involved, then you don't have to worry. Warn the patient that some muscles, hand muscles or foot muscles, may be more sensitive than others. Reassure that the patient that he or she can choose to discontinue the test at any time. So don't prolong the agony if they are not able to tolerate it. What is the protocol of the EMG procedure? First, localize the muscle. Find the muscle belly by using surface landmarks. So this anatomy identification of muscles is very important, where your flexor carpi radialis is there, where the first dorsal interosseous is there, where abductor pollicis brevis is there in the upper limb, where biceps, triceps, where you're going to do deltoid, where you're going to do. These things should be very clear in your mind. Confirm the position of the muscle belly itself. To do this, palpate the muscle belly and ask the patient to activate the muscle. The examiner should feel the muscle contraction. Now, clean the area with alcohol swab and let it dry. Warn the patient before each new needle insertion. His cooperation is very important. Now, insert the needle. How will you insert? Retract the skin, making it taut, which helps the needle enter more easily. In one quick motion, insert the needle tip through the skin into the subcutaneous tissue. Going slowly or softly increases discomfort. So, when you're piercing the skin, it should be quick. And if using a concentric needle, keeping the bevel up during insertion will minimize the discomfort. Advance the needle through the subcutaneous tissue until the needle enters the muscle. Once in the muscle tissue, ask the patient to slightly activate the muscle to confirm the proper placement, because MUAPs will be visible on the screen. Provide sufficient resistance to ensure a gentle isometric contraction. Needle is correctly placed, electrical activity will be seen on the screen, and here also the muscle unit, motor unit action potential. So you can see the motor axon here. This is the motor axon, and these are the muscle fibers. They are muscle fibers which have got a lot of myofibrils inside. These are the muscle fibers. You can see the longitudinally placed muscle fibers. And what is the important point in a motor unit is that the motor axon, it supplies the branches of motor axon go to different muscle fibers, and they are not at the same place. So it may be having here, it may be having here, it may be having here. They are not continuous. They innervate at many places at random. Motor unit anatomy. So you can see the muscle, the reference electrode, also the ground electrode, and the needle, that is the concentric needle that is being used, that is a monopolar needle. And then you have to show slight contraction. You can see the contraction, mild isometric muscle contraction is happening here. And when that happens, you can see the MUAP on the screen. And why do we do MEMG? If there are root and plexus lesions, nerve conduction is limited to CAT1 and L5S1 in lower limbs. See, what do you do in upper limbs nerve conduction? A median nerve, in ulnar nerve, sometimes radial. In the lower limbs, commonly you do common peroneal or posterior tibial nerves. So their root values are CAT1 and L5S1. So we are not screening C5, C6, C7 here. We're not doing L2, 3, 4 here. So you have to choose different muscles to determine a root level. Same root level, different now. Paraspinal muscle involvement is present or not, because if it is present, that is a radiculopathy. That's very important. Paraspinal EMG is very important. And you can also diagnose compressive and trapment nerve lesions. Choose different muscles to determine a nerve involvement. Same nerve, different roots. Determine whether lesion is affecting myelin or axon or both. Compare to nerve conduction studies. So nerve conduction studies will tell us some idea if it is an axonopathy or demyelinating. If it is affecting myelin, that distal latencies will be prolonged, F waves will be prolonged. The MUAP, the CMAP may be slightly polyphasic or increase in the duration, and there may be conduction block. And if it is axon, there will be lack of amplitude, and the amplitude gets reduced in axonopathy, and compared to nerve conduction studies. So you can also assess the age of the lesion by observing about FIPS and polypositive shock waves, etc., which will happen after more than 3 weeks. So Soon after the injury, if you do, you will not see anything because these fips and fibrillations and positive sharp waves which are going to learn, they happen only after 3 weeks. So if anybody refers to immediately after injury, please ask them to come back after 3 weeks. Polyphagia will take 3 months. So if you see polyphagia on EMG, you can clearly think that it could be 2 months ago. And usually long duration is after within 8 months. Although it's long duration means it's a chronic episode that happened. So what are we going to do? Insertional activity, spontaneous activity, which may be normal, abnormal, we're going to study. The muscle during activation, mild effort, moderate effort, full effort. And what we're going to study is motor unit action potential in EMG. CMAP we're going to study in neuroconduction studies. So when performing the needle EMG, the electrical activity seen on the screen can be broadly categorized as insertion, voluntary, or spontaneous. The insertional activity is the electrical activity caused by insertion or movement of a needle electrode within a muscle. That is what you see on the screen before you move the needle. So I will describe how to examine by 4-quadrant method of insertional activity in the coming slides. Electric activity is recorded from a muscle with consciously controlled contraction. That is, you ask him to slightly contract, slightly more severe, and forcefully contract. So these are the 3 activities which we ask the patient. We have to identify the muscle and show him the movement, how it is to be done, and ask to tell them that it has to be done mild, moderate, and very forceful. Spontaneous activity is seen when the limb is totally at rest. Electric activity recorded from a muscle at rest after insertion activity has subsided and when there is no voluntary activity, that is, the needle is not moving, the patient is completely relaxed. This is the most difficult part in the EMG because you put in a needle into the body and there is pain and you ask him to relax, and it's going to be very tough, but you have to make him comfortable, make him there should no activity at all from the muscle contraction side, then only you can witness the spontaneous activity. Noise from nearby equipment, pacemaker spikes, loose electrodes, faulty wires, cables, ringing cell phones, etc. will cause artifacts in the study. Insertional activity and spontaneous activity. So first of all, evaluate insertional and spontaneous activity when you do EMG for each muscle. So each muscle should be studied in 4 parts, and first part is insertional activity, second part is spontaneous activity. This is done by using a 4-quadrant technique. That you are studying the insertional activity. In each quadrant, do the following: advance the needle 5 times in a straight line. Each of these advancements should be small, 1 millimeter or less, to minimize patient discomfort. Inside the muscle, even the needle moves, there will be less pain. Between each advancement, wait 1 to 2 seconds and listen for insertional and spontaneous activity. Once 5 locations in a quadrant have been evaluated, slowly retract the needle until it is out of the muscle but remains in subcutaneous tissue. Adjust the needle position and examine the next quadrant. So the 4-quadrant technique is used to assess the EMG insertional activity and spontaneity, but usually it's very painful, and at least 2 quadrants you try and see whether you can do, and 4 quadrant is the ideal one. Insertional activity starts as you insert a needle into the muscle. It should stop and become flat when you stop the insertion. This is a normal insertional activity. You can see it's going to stop here. And it is the spontaneous activity, the insertional activity can be painful now whenever end plate potential is encountered, when the needle is near the nerve entry point into the muscle. That is the end plate, and when the needle is there, there will be pain. It sounds like a seashell noise, and it will not stop unless the needle is removed, and it can be painful too. Then you see these end plate spikes which you're going to get. Fibrillation potential is the one which you can see the fibrillation potential morphology here. When the muscle is totally relaxed, the needle is in the muscle, and you've done the 4-quadrant method. You are advancing 1 mm at each time, and 5 times in each quadrant, you will encounter the fibrillation potentials, which will look like this. And these are the end plate spikes, which when the patient complains of pain, you should slightly withdraw and reposition. These are the fibrillation potentials. And the positive sharp waves, and the positivity is down here. Positive sharp waves are look like this. These are also spontaneous, part of the spontaneous activity. And sometimes you get complex discharges like this, right? So there's a grading of the sharp waves and fibrillation potentials. If there's +1 fibrillation potential present in at least 2 areas, and +2 in 3 or more areas, large number of the persistent discharges in all areas is +3. Profuse, widespread, persistent discharge that fill the baseline is a +4. That's how you grade these FIPS and the positive short waves. The motor unit action potential, the summated electrical activity of muscle fibers innervated by single axon. I showed you the motor axon. It only reflects those fibers within the range of the needle electrode. The amplitude is usually reflects no more than 10 muscle fibers in the vicinity of the electrode, while all of the muscle fibers belonging to the motor unit contribute to the duration. And usually it is triphasic. The amplitude of a first observed MUPs should be 300 to 500 microvolts. Later recruited MUPs up to 3 millivolts, and giants refer to more than 5 millivolts, a giant MUAPs. And duration is normally 5 to 15 seconds. It typically starts at 3 to 5 hertz and increases with effort up to more than 30 hertz, not regular but semi-rhythmic. Polyphasic MUAPs, 5 or more phases, up to 10 to 25% of recorded MUAPs may be polyphasic in normal muscles depending on the needle positioning. When pathological, it can be caused by collateral sprouting seen with denervation, or dropout of muscle fibers seen with myopathy. And you can see fasciculation potentials, which are sporadic. You can see myochemic discharges. These are grouped fasciculations, neuromyotonic discharges, and cramp potentials. These are various things which are going to see the spontaneous activity. And let us learn about fasciculation potential. It is the same configuration as MUAP. Sporadic versus grouped sounds like a bird dropping against the windshield of a fast-moving car. Quack. Single, random, spontaneous twitch due to hyperirritation somewhere along the neuron, which activates all or significant number of muscle fibers belonging to a single motor unit, very often normal, can also be grouped in pairs, doublets, or triplets. The fasciculation potentials are most commonly seen in deltoid muscle. Myochemic discharges, grouped fasciculation, same configuration as the MUAP, but two distinct firing patterns are seen. The brief uniform repetitive firing of MUAP, that is 40 to 60 hertz up to few seconds, brief periods of interposed silence, and sounds like the burst of machine gun fire or the drum solo from One by One Metallica. This continuous recurrent uniform slower firing can be there, sounds like marching soldiers. These are myochemic discharges. They originate somewhere along the motor neuron, irregular discharge of motor unit possibly with ephaptic transmission, sometimes seen with demyelinating conditions. And neuromyotonic discharges, they are abrupt, they start and stop. They are fast firing of MUAPs for a few seconds, 100 to 300 hertz. They progressively decrement and decrescendo, the characteristic of ping pong sound. The burst of MUAPs originating at the motor axon, seen in the Isaac syndrome neuromyotonia. Cramp potential, same configuration as MUAP, start and stop gradually. So you're going to learn what is the normal morphology of MUAP, but just learn these are things which are dependent on MUAP. The cramp potentials are painful, involuntarily firing MUAPs, organizing in motor nerves, can also be seen with fatigue or electrical imbalance. So spontaneous electrical activity, let's continue. Miniature end plate potential, end plate noise. Small, 10 to 50 microvolts. Duration, 2 milliseconds. Approximately every 5 seconds per axon terminal, but clinically multiple observed at once. There can be multiple miniature potentials. Regular rhythm. The initial negative, that negative means like this. And seashell murmur, random spontaneously released acetylcholine vesicles from the nerve terminal. The baseline elicit non-propagating discharges at the muzzle end plate. That's what causes the miniature plate potential or end plate noise. End plate spikes are less than 300 microvolts, 2 to 4 milliseconds, 50 to 100 hertz, irregular, biphasic with initial negative deflection. This is the negative deflection. This is the negative deflection, and sputtering fat and frying pan. That's the sound which you can see. It is the irritation by the needle electrode of the terminal axon, which results in a suprathreshold end plate depolarization of the single muzzle fiber. So fibrillation potentials or FIPS are positive shock waves. They are less than 1 millivolt, less than 5 milliseconds, usually slow but wide range, often decreases just before cessation. Usually they are regular, tuck, tuck, tuck. Biphasic with initial positive deflection, rain on a rooftop and ticking positive shock waves, the dull thud. FIPS are generated by one single physiologically unstable sacrolemma. The resting membrane potential slowly creeps upward until the threshold is reached. A spontaneous depolarization then occurs, which is followed by repolarization, with the cycle beginning over again. The positive shock waves are thought to be a variation of the fibrillation, except that the muzzle fiber at the recording site is deformed by the presence of the needle electrodes, which you are pushed inside. The unstable resting membrane potential, which leads to fibrillation potentials, or positive shock waves, can occur from direct muscle injury, that is trauma, inflammation, or denervation. Complex repetitive discharges, CRDs, they are less than 1 millivolt, variable but start, stop abruptly, and up to 150 hertz. They are regular, may display abrupt changes in configuration. They sound like a machine. Group of single muzzle fibers, they spontaneously depolarize in a set pattern directed by a primary pacemaker fiber. Usually seen in chronic processes where a group of muzzle fibers becomes unstable, similar to those of FIPS and positive shock waves. These are suggest denervation, and they can also be seen in spontaneous activity, myotonic discharges like 10 microvolts to 1 millivolt. Duration is more than up to 10 and 100 hertz, waxing and waning, dive bomb type, and amplitude and intermittent rapid, repetitive, variable, waxing and waning amplitudes, frequent firing of FIPS or positive shock waves which appear, which has the potentials, the APS appear. The primary defect, membrane ionic conduction characteristics, and requires needle movement, muscle contraction to elicit this dive bomber, which is seen in myotonia congenita and myotonia atrophica. The abnormal insertional activity, the fibrillation potentials and positive waves seen early denervation, typically 3 weeks after the lesion, which is this what you see. It is not painful if and does not stop if you pull the needle away from it, and it fires very regularly. So that's how you identify. While doing that, that is the FIPS and positive shock waves are very regular. Let's look at the MUAP analysis. A motor unit consists of a single motor neuron and all the muscle fibers it innervates, but they are at various places. The number of muscle fibers innervated per motor neuron is referred to as innervation ratio. This innervation ratio differs from the fast-acting muscles to slow-acting, depending on the muscle size. Muscles that are used for precise movements generally have smaller innervation ratios. The motor unit action potential is the EMG response that results from the discharge of all the muscle fibers that are innervated by a single motor neuron. And MUAP, therefore, it represents the summation potential of all of the muscle fiber action potentials that are elicited by their common motor neuron that are close enough to the tip of the recording electrode to be able to be registered. The size and the shape of MUAPs are dependent on the size, number, and functional state of the muscle fibers innervated by a single motor neuron in the region of the recording electrode. I showed you the diagram, which the diagram again we'll see. So we have to describe the MUAP amplitude, the duration, the phases, and the stability. In the healthy state, MUAP is stable due to the all or none nature of action potentials, as well as the reliability of neuromuscular transmission. Safety factor is there. Denervation, dysfunction of the NM junction, altered excitability of the muscle fibers may cause MUFs to become unstable, that is, having variable sizes, shapes between consecutive discharges. The firing characteristics and recruitment of motor units can also be quantified, enabling the identification of different patterns of pathology of the neuromuscular system. So the duration of MUF is look total amount of time of the recorded potential and is measured from the initial deflection from the baseline potential until the final return to the baseline potential. I'll show you the diagram. MUF duration correlates with the number of muscle fibers that are innervated by single motor neuron in the region of the recording electrode. During processes of muscle fiber degeneration or inexcitability, the MUAP duration will be shortened. During process of denervation, collateral sprouting, reinnervation, increased numbers of muscle fibers will be innervated by a single motor neuron in the region of the recording electrode, leading to increased MUAP duration, also giant action potentials. The duration are between 5 to 15 milliseconds is a normal value. If it is more than that, that is abnormal. The amplitude is generally measured from the maximal negative peak to the maximal positive peak. Now, if you like this, it's from here to here. The amplitude of the MUAP reflects the number of muscle fibers innervated by single motor neuron in the region of the recording electrode. This is also influenced by the size of the individual muscle fibers closest to the recording electrode. Therefore, MUAP amplitude is less well correlated with the numbers of muscle fibers innervated by a motor neuron. So reference values of MUAP amplitudes are related to the electrode type. The normal amplitudes MUAP is between 100 microvolts and 2 millivolts. If it is more than 5, we call it the giant. Upper limit of 6 MV is generally used for a monopolar electrodes and 4 MV for concentric electrode. But anything above 5, we call giant motor unit action potentials. So this is the amplitude which you are from here to here. These are the phases which have to cross the baseline. This is the duration from here to here is the duration. These are turns. These are turns which you are seeing 1, 2, 3, and 4. Normally is three triphasic. The term phase is used to describe the individual components of a motor unit action potential that are above and below the baseline. The number of phases in an MUP can be calculated by taking the number of baseline crossings and adding 1. In the figure, it is 1 plus 1, 2. The 1 plus 1, 2. So this is one which is crossing the baseline. So the turn describes a change in amplitude of the MUP that does not cross the baseline. The turn, this is not a, the turn means it is not crossing the baseline. So turns are not to be counted, phases are to be counted. Most MUPs will have between 2 and 4 phases. MUPs with greater than 4 phases are referred to as being polyphasic. Polyphasia is the result of desynchronization of the summation of the muscle fiber action potential that contributes to MUAP. Desynchronization can occur due to early reinnervation as well as degeneration and regeneration of muscle fibers. The polyphasic MUPs are non-specific. A percentage of MUPs within a healthy muscle will be polyphasic, that 20% almost. So what is stability of MUAP? An MUAP represents the summated muscle fiber action potentials within the recording area of the needle electrode that are innervated by a single motor neuron. In the healthy state, due to both the all or none phenomena of the muscle fiber AP section potentials, the reliability of neuromuscular junction transmission and the MUAP potential size does not vary between the discharges and is completely stable. If the size is varying between the discharges, that becomes unstable. If changes in MUAP size and shape are observed in a healthy patient, is most likely related to movement of either the needle electrode or the muscle. But in contrast, pathological changes such as abnormal neuromuscular junction transmission, abnormal excitability of muscle fibers can result in variability of MUAP size, shape between the consecutive discharges. Short duration, small amplitude, polyphasic MUAPs are characteristic of myopathic process. A variety of myopathic processes can result in disruption of the muscle fiber action potential generation. Some of these include immune cell invasion of the muscle fiber, that is inflammatory myopathies, dermatomyositis, polymyositis, Necrosis of muscle fibers, immune process, toxic exposure, and inexcitability, periodic paralysis. So in periodic paralysis, if you put in a needle, there will be no MUAP. Loss of muscle fiber integrity or function may result in loss of muscle fiber action potential generation. Losses of muscle fiber action potential result in a reduced size of the summated MUAP amplitude during an EMG recording of a myopathic muscle. So in periodic paralysis, it is inexcitability. In cases of very chronic myopathies characterized by cycles of degeneration and regeneration of muscle fibers, such as milder forms of muscular dystrophy or inclusion body mass, it is MUAPs become complex and polyphasic in appearance, are generally reduced in myopathies, MUAP amplitudes, because of a reduced number of the excitable muscle fibers, where chronic myopathies can display muscle fiber hypertrophy, which in turn can lead to MUAPs with increased amplitude. But by and large, small amplitude MUAPs, polyphasic, they are characteristic of myopathy. Increased MUAP amplitude in myopathic condition usually reflects muscle fiber hypertrophy rather than grouped reinnervation that happens in neuropathic patterns. Increase in number of muscle fibers being innervated by the same single motor neuron in the region of the recording electrode. So now let us look at what is a denervation, reinnervation pattern which we have to observe and give reporting. Long duration, large amplitude, polyphasic MUAPs are characteristic of neuropathic process. That is giant MUAPs. Denervation leads to reduction in the number of motor neurons or units that are functionally connected to a particular muscle. In the acute setting, up to 8 weeks, this, however, does not usually result in immediate changes in MUAP size or shape. So there's no point in doing the EMG test. Denervated muscles can be reinnervated through mechanism of either collateral sprouting or axonal regeneration. And collateral sprouting occurs when the denervation is partial or incomplete. Terminal axons are the motor units that are intact sprout to reconnect to denervated muscle fibers. Following collateral innervation, a single motor neuron will have increased number of muscle fibers it innervates. In the region of the recording electrode, the resulting MUAP will be increased in size, both amplitude and duration. That means giant MUAP. As it takes time for these new axon, collateral sprouts, and neuronal junction to mature, during early stages of reinnervation will have increased polyphasia. So giant MUAP suggests neuropathic pattern. MUAP changes in collateral sprouting are usually noted approximately 8 weeks following denervation. So in contrast to collateral sprouting, axonal regeneration is a delayed phenomenon dependent on the axonal regrowth from the site of nerve injury towards the denervated target muscles. So in disease, during axonal regeneration, the first synaptic connections made with a denervated muscle will be with only a few muscle fibers, resulting in MUAPs of reduced size. They are called nascent potentials, nascent MUAPs. Early, small, immature MUAPs that result from an axonal regeneration. Sometimes they are called nascent MUAPs. Over the time, these nascent MUAPs can become larger as more muscle fibers are reinnervated. In contrast, the collateral sprouting, which is usually evident within approximately 8 weeks, the efficacy and timing of the axonal regeneration is dependent on the distance of the target muscle from the site of nerve injury. So longer distances between the target muscle and the site of injury result in longer duration prior to reinnervation as well as less effective reinnervation. So in this slide, we learned about nascent MUAPs. You can see the needle which is closed. These are all the fibers, muscle fibers. You can see the needle has entered and you can see the MUAP that is seen, which are called amplitude, duration, and phases are all depend on this. Isolation of a motor unit with the needle in the subcutaneous tissues. Ask the patient to minimally activate the muscle that is being tested. Provide slight resistance sufficient to ensure an isometric contraction. Ask the patient to contract more or less to identify a predominant individual motor unit and properly assess motor unit recruitment. Advance the needle into the muscle, adjust the needle to best analyze an individual motor unit potential. So you can see the amplitudes, the phases, etc. And so this is a very important diagram for understanding. Needle EMG picks up MUAP. The amplitude is determined by 2 to 3 fibers which are nearer to the needle tip, whereas the duration is due to all the muscle fibers belonging to the motor unit. These motor unit fibers can be here can be here, can be here. So all these will account for the duration, but the amplitude is determined by 2 to 3 fibers which are nearer to the needle, like this one and this one. Okay. So the MEP is seen after activating the muscle. So every time you have to teach the patient that mild activation, slightly more and slightly more. So MEP is seen after activating the muscle 1 to 3 phases. The number of units goes up as the effort is increased. That is called recruitment. It needs to be observed at mild, moderate, and full voluntary effort. These are the normal motor units, which you can see the phases that are going down, the turns. This is a turn, and this is the phase that is going down. Seen in chronic nerve injury, long duration and polyphasic, which you can see here. These are the polyphasic MEPs, 4 to 5 phases. Sounds thundery on screen. More recent nerve injury shows polyphasia. Old injury shows longer duration, that is more than almost 6 months. So you can see now, these are the grouped collateral sprouting, and these are neurogenic EMG, which will give you a giant MEPs. And here there is grouping of muscle fibers. That's why the duration is increased. So now we'll go to the last part of the EMG technique, that is recruitment. Ask the patient to maximally activate the muscle being tested and provide resistance sufficient to ensure an isometric contraction. Maximal intensity muscle contraction with a needle inserted can be very uncomfortable for the patient. This technique should be used sparingly. So motor unit recruitment refers to the sequential activation of motor units during an increasing muscle contraction. Recruitment is one of the main aspects of MEP analysis during the needle EMG examination. So insertional activity, spontaneous activity, MEP analysis, and recruitment. It can be used to distinguish normal versus underlying myopathic or neuropathic conditions. Complete recruitment is in myopathy, incomplete or that is neuropathic conditions seen. So how many screens are there in a second on the screen, what you're seeing? What is the sweep speed of sweep speed of 10 milliseconds per division? And the time period contained in one screen is 10 boxes. 10 boxes means like this, 10 boxes on the screen. 10 into 10 milliseconds, that is 100 milliseconds per screen. And 1 second is equal to 1000 milliseconds. 1 second is equal to 1000 milliseconds. So screen in 1 second is equal to 1000 milliseconds by number of milliseconds per screen. So here 100 milliseconds, that is 10 screens per second you have to see. The speed of 20 milliseconds per division. The time period contained on one screen is 10 boxes into 20 milliseconds is the per division, that is 200 milliseconds per screen. That is the time duration. So screens in 1 second is equal to 1000 milliseconds by number of milliseconds per screen. That will be 5 screens per second. So you can the 10 milliseconds division, 20 milliseconds per division. So you can see how many screens are there in a second. So you carefully observe what is the sweep speed which you have put for the EMG. So you can calculate the firing rate, determine how many screens are there in 1 second, how many of the same motor units are on the screen, multiply them together. Example, you calculate the firing rate of the fastest MUAP where the sweep speed is set to 10 milliseconds per division. 2 motor units are noted on the screen. So 10 boxes per screen, 10 milliseconds per 100 milliseconds per screen. And 1000 milliseconds per second by divided by 100 milliseconds per screen is equal to 10 screens in 1 second. 10 screens into 2 motor units per screen, that is 20 hertz is the firing rate which you can calculate. So you can calculate the recruitment ratio, contract the muscle with minimal to moderate force, calculate the firing rate of the fastest motor unit action potential, count the total number of discrete motor unit potentials on the screen, divide the firing rate by total number of discrete motor unit potentials. So that you can see, and recruitment ratio can be calculated like this. That's anyway advanced, so you will learn it when you start reading yourself. So motor unit recruitment, normal, early recruitment, myopathic, decreased recruitment, neuropathic pattern. So this is a normal recruitment. The early recruitment, which is a myopathic pattern, and very early decrease. So small amplitude, polyphasic, early recruitment is myopathic, incomplete or decreased is neuropathic pattern, and normal recruitment of 3 MUPs during concentric needle electromyography of a muscle during a gradually increased contraction. So you can see A, and this is 100 microvolts and the 100 milliseconds, and you can see two of them, and you see as the recruitment goes, a third MUP is recruited as you force on it. So as you increase the force, the more of the recruitment of more MUPs is seen in this. First, there are three are recruited, more than three are recruited. So during muscle contraction, motor unit discharges. Under voluntary control, motor neurons and motor units fire semi-rhythmically and no slower than 4 to 5 hertz. Normal contractions, the maximal motor firing rates are usually less than 50 hertz per second, but during ballistic contractions, it may go up to 100. According to size principle, during gradually increasing muscle contractions, smaller motor units, that is innervating type 1 muscle fibers, are recruited first, followed by the larger motor units innervated by type 2 muscle fibers. So recruitment is a very important aspect and particularly helpful in identifying disorders of the peripheral nervous system. Simply stated, recruitment is assessed by the whether the MUP is activated during a muscle contraction or firing at the appropriate rates. It is best evaluated minimal to moderate levels of muscle contraction to allow discrete discernment of the individual MUPs, because you have to calculate the ratio also. Recruitment pattern can be described as normal, early, as I said earlier, early in myopathic conditions, late in neuropathic conditions, and it is incomplete in neuropathy. Recruitment can be quantified using a recruitment ratio. Myopathic conditions, to again state, result in early recruitment with the increased numbers of motor units recruited than would be expected for force produced during a muscle contraction. It is not altered in upper motor neuron pathology. The MUP is same, recruitment is same. In human disorders or insufficient patient effort, activation of MUPs, motor units may be reduced, resulting in reduced numbers of the motor units firing at low frequencies. What is the clinical utility? Recruitment analysis can help identify a myopathic versus a neuropathic process. That again, I'm hammering this point again and again. Decreased recruitment may be present immediately following axonal injury or dysfunction. The decreased recruitment is an early finding as compared with the other findings such as MUP morphological changes or membrane instability, that is abnormal spontaneous activity. So stepwise approach to recruitment assessment: confirm that the gain and the sweep speed settings are appropriate to fully view the MUPs and to allow the recruitment quantification. Sensitivity testing will depend on the size of the MUPs and should be set to allow full visualization of the MUPs. Sweep speed is somewhat dependent on the personal problem, but it is usually set to 100 or 200 milliseconds. Based on the differential diagnosis, determine the muscles to be tested. Place the patient in a position of comfort that facilitates isometric contraction. The patient perform a minimal to moderate contraction to allow the visualization and analysis of discrete MUAPs. To assess recruitment, the number and firing rates of MUAPs present in a contracted muscle need to be determined. So newer electrodiagnostic devices allow storage of EMG signals for a review after completion of the muscle assessment. This can be particularly helpful feature of for less experienced electromyographer, which you can sit later and identify. Distinct MUAPs are identified and quantified based on different waveforms and shapes. So to calculate the firing rate of an MUAP, simply determine how many times the MUAP is seen within a span of 1 second. If the sweep speed of screen is set at 200 milliseconds, multiply the number of MUAP occurrences by 5. If it is set 100 milliseconds, multiply the number of occurrences by 10. Then you get the rate of MUA firing rate. So the confluence of motor units that appear on the screen with maximal muscle activation is the interference pattern, which is what we are going to discuss. For a normal healthy muscle with intact motor unit innervation, maximal contraction results in MUAPs filling the entire screen. Performing maximal contraction in a healthy muscle with intact innervation usually does not provide valuable information but can be painful for patients. Neuropathic processes, loss of motor units will result in reduced interference, sometimes referred to as picket fence pattern. For myopathic processes, the interference pattern may be fill the screen, assuming there isn't severe muscle loss, but the MUS will be reduced in size. So, in short, what are the findings in neuropathic process? In neuropathic process, loss of MUAPs may be the result of either conduction block or axonal loss. The remaining MUAPs recruited during a muscle contraction will be firing at a higher than expected rate. In the case of chronic axonal nerve injury, recruitment may be normalized. The motor units are able to re-establish normal innervation patterns via axonal sprouting. In contrast, collateral sproutings will not correct reduced or late recruitment following axonal injury, although MUAP size will increase in amplitude and duration due to increased numbers of muscle fibers innervated by a single motor. So you get a giant MUAP. In myopathic processes, muscle fibers undergo degeneration. Therefore, each motor unit produces a reduced force output during muscle contraction. For a given level of contraction, myopathic muscle, an increased number of MUAPs will be recruited, and it is early recruitment, increased recruitment, which is out of proportion for the resultant muscle force. So, in short, the neuropathic potentials: increased motor unit action potential, duration, amplitude, polyphasia, decreased recruitment or picket fence pattern, and recruitment ratio is increased. In myopathic, decreased duration, amplitude, polyphasia, early recruitment, and recruitment ratio is decreased, right? So that's how the abnormal pattern of MUP recruitment 200 and 2 millivolts. See, if you see, then you can see the recruitment. Early recruitment, short duration MUAPs in a patient with inclusion body myocyte is providing a weak muscle contraction. Late recruitment in a patient with chronic motor neuron disease displaying a large amplitude MUAP with a firing rate of approximately, this MUAP is very large and 2 MV. So there is a calculating of firing rate, and you can see there are two here. This is 100 microvolts, 100 milliseconds. Determine how many screens there are in 1 second. The screen sweep speed equals 100 milliseconds, 100 milliseconds per division, 100 milliseconds per division, and 1000 milliseconds by 100 milliseconds, 10 screens in 1 second, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 divisions. In 10 screens in 1 second, how many times an individual MUAP appears on the screen? 2 times. The fastest MUAP is seen twice on the 100 millisecond screen like this. This is 100 millisecond screen. Multiply the number of screens in a second by the number of occurrences of the particular MUAP to determine the firing rate. Firing rate is 2 MUAPs into 10 screens in a second. So that will be 20 hertz. That's how you calculate the firing rate. So firing rate of the fastest MUAP. Now you see there are more MUAPs here. As calculated earlier, the fastest firing MUAP is seen twice per screen. The number of screens is in 1 second is 10. Therefore, the firing rate of MUAP is 2 hertz. And the number of MUAPs on the screen now, there are 3 here, right? This is 1, this is 2, this is 3, and again the second one. So there are 3 of them here. Total of 3 distinct MUAPs are seen. Divide firing rate by total number of MUAP 20 by 3. That's how the recruitment ratio is calculated. So recruitment, normal, late to normal, early. This we have already discussed, and the recruitment ratios, maximal activation, influence pattern we have discussed. So interpretation of the EMG results. So there are 4 components, as we said, of the needle EMG that are used to guide interpretation. That is insertional activity, motor unit morphology, motor unit recruitment, and pattern of muscle abnormalities. The electrical activity associated with the movement of the needle through the muscle and for several seconds after stopping the needle movement is insertional activity, and that 4-quadrant method, don't forget, normal electrical signal with the movement of the needle in the muscle with no prolonged activity after stopping the needle movement, except in neuromuscular end plate region, where there may be miniature end plate potentials and end plate spikes may be seen after the needle movement is stopped. But it is normal muscle, reinnervation, old innervation, myopathy, neuromuscular junction disorders. There are 4 components of needle EMG that are used to guide the interpretation, and insertional activity, motor unit morphology, motor unit recruitment, pattern of muscle abnormalities. So normal, increased insertional activity, decreased insertional activity. The brief bursts of electrical potentials due to mechanical depolarization by the needle deforming the muscle membrane less than 300 milliseconds. If it is more than 300 milliseconds but less than 2 to 3 seconds, any activity lasting longer should be re-evaluated as possibly being voluntary or spontaneous, may reflect denervation or membrane instability. It is decreased little or no activity with needle movement. First, ensure the needle is in the correct location. Can be seen with fibrosis, edema, and electrolyte disturbance, especially periodic paralysis. The insertional activity increased, continued electrical activity, stopping the needle movement, is seen in cases of inflammatory myopathies. Positive waves and fibrillations indicate denervation. Complex cerebral charges may be seen in chronic denervation. Myotonia associated myotonia congenita, myotonia dystrophica, neuropathic radiculopathies can also have the myotonic discharges. The insertional activity is decreased, lower amplitude, muted sound of electrical activity. There is no sound of the movement in the muscle. This is in fibrous replacement and electrical disturbances. So number of phases, 4 or less phases is normal finding, and more than 4 is, and any injury, the abnormality is seen only afterwards. In seen normal recent denervations, less than 6 weeks also you can see 4 or 5 phases. And abnormalities, 5 or more phases, are polyphasic and abnormal, and they are seen in nerve sprouting, reinnervation, as I said earlier. And motor unit morphology, reputational review, 5 to 15 milliseconds, generally normal, but varies from the muscle, normal in normal muscle, early denervation, old reinnervation, and it is increased in chronic denervation associated with polyphasic potentials, and it is decreased in myopathy. The amplitude is normal is 200 to 2000 microvolts, generally normal, but varies by, that is 2 millivolts. If you say you want to say that, the normal early and chronic denervation also it is normal. It is increased in old reinnervation and decrease in myopathy. Repeated firing of motor units during muscle contraction is recruitment. This decreased rapid firing frequency of fewer motor units seen with conduction blocks and denervation. It is increased many motor units with minimal force generated seen with myopathy. Maybe normal, mild denervation. So increased in myopathy is the important point which you have to. There may be focal mononeuropathy, radiculopathy. There may be a pattern of muscles which to be involved. 2 or more abnormal muscles innervated by the same peripheral nerve but with different nerve roots. In median mononeuropathy, the median innervated flexor carpi radialis C6, C7, abductor pollicis brevis T1 are abnormal, but the radial innervated triceps C6, C8, ulnar innervated abductor digiti minimi are normal. So 2 or more abnormal muscles innervated the same peripheral nerve but with different nerve roots, such as focal mononeuropathy. 2 or more abnormal muscles innervated by the same nerve root but innervated by different peripheral nerves. Tibialis anterior L4, L5, and tensor facial at L5, S1, and would be abnormal in L5 radiculopathy. So, but muscles without L5 innervation would be normal, like medial gastrocnemius will be normal. So plexopathies requires a knowledge of the brachial and lumbosacral plexus, which we'll deal separately later on. In a posterior cord lesion, the deltoid C5, C6 upper trunk, posterior cord, axillary nerve, extens are indices, C7, C8 middle and lower trunks, posterior cord, radial nerve would be abnormal. So that we'll again discuss when we deal with plexopathies in detail. Other muscles supplied by the same cervical roots and trunks would be normal. So common patterns include abnormal muscles affecting one cord, one trunk, or several isolated nerves from the plexus. More than one abnormal muscle innervated different peripheral nerves and roots distally, with sparing of proximal muscles innervated the same peripheral nerves and roots, suggest the peripheral neuropathy, the dieback phenomenon. The deep fibular nerve, common peroneal nerve innervated, extensor digitorum brevis in the foot is abnormal. The tibialis anterior, which also has deep fibular nerve supply, is normal. That is peripheral neuropathy. Myopathy commonly affects proximal upper and lower limb muscles symmetrically. More distal muscles are typically normal. So The needle exam changes over the time after axonal nerve injury. Immediately, there is a decreased recruitment of normal appearing motor units. Normal insertional activity, it takes about 1 to 6 weeks after nerve injury for the Valerian degeneration, muscle membrane instability to occur. So there will not be any fibrillations or positive shock waves till 6 weeks. 1 to 3 weeks, decreased recruitment as previously described. Denervation of the paraspinal muscles, because the paraspinal muscles are the most proximal muscles, they're first to show signs of denervation. Paraspinal muscles may have positive shock waves and fibrillation starting 1 to 2 weeks after the acute injury. 3 to 6 weeks, there is decreased recruitment, paraspinal muscle denervation as previously described, active denervation of the limb muscles. At 3 to 6 weeks, Valerian degeneration has occurred and positive shock waves and vibrations appear in the distal muscles, and abnormalities will be seen lost in the foot and hand muscles. 6 weeks to 1 year, the decreased recruitment, positive waves, fibrillations appear as muscle fibers are reinnervated. Motor units with long duration and polyphasia. 6 weeks to several months after the injury, axonal sprouting occurs. This means that the remaining axons will now be innervating muscle fibers that were denervated because the newly formed nerve sprouts innervating these muscle fibers conduct more slowly. They will not fire synchronously with the rest of the muscle fibers and that are innervated by the motor unit. Therefore, the motor unit morphology will have longer durations with increased phases. And up to 1 to more years, decreased recruitment, polyphasic motor unit becomes triphasic because motor units now have mature myelin on the sprouts that innervated the denervated muscle fibers and fibers fire synchronously. Motor units have large amplitudes because of the synchronous firing of the larger number of muscle fibers. So lastly, we'll see EMG of upper extremity and then finish off. So first dorsal interosseous, ulnar nerve CAT1 roots. Abductor pollicis brevis, median nerve CAT1 root. Flexor carpi radialis, median nerve C6 C7 root. Brachioradialis C5 C6 root. Triceps radial C6 C7. Deltoid axillary C5 C6. Cervical paraspinal C5 T1 roots. So you can see upper extremity, same root, different nerves. Same root, CHT1, but nerves, ulnar and median. What are the muscles? If you are testing for the same root, and you have to test two muscles, that is first dorsal interosseous, which you can see here, and also abductor pollicis brevis, which you can see here. And upper same root value, different nerves. The same root value but different nerves, that is median nerve, flexor carpi radialis, and triceps radial nerve C6-7. Both are C6-7 nerves. And different root values, same nerve again, APB and flexor carpi radialis, median nerves, and C6, C7, CAT1. So same root value, different nerves again, radial and deltoid axillary. So that's how you have to check out your plan of EMG very well in advance. This is a cervical paraspinal muscles, which we said that they'll show fibs and positive shock waves very early, 1 to 3 weeks after the injury. So paraspinal EMG is very important. So the procedure protocol after each muscle is examined, remove the needle, apply local pressure with sterile gauze to achieve hemostasis. After each muscle examined, clean the area if necessary. Ask the patient frequently how she or she is doing. Adjust your technique as necessary. Completion of the study, dispose the needle in a sharp container where, when finished, reassure the patient about his or her cooperation, sympathize with any discomfort, reassess the patient for areas of pain, bleeding, or bruising. The patient has any questions or concerns before leaving, describe the results of the test to the appropriate extent. What we're going to discuss that in subsequent classes. That's all for today. Thank you very much for your patient hearing, and we'll have more of these in the coming weeks. Individual diseases will describe more. Hello. Yeah. Good evening. ठीक है. Continue, sir. Yes, 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 yes. So, any questions? If there are anything, but subsequent classes we will be dealing each individual entity. About next 5 to 10 classes we can finish the EMG in greater detail. This is only sensitization of what is the EMG and what we study. And now we'll deal separately with radiculopathies the flexopathies and also neuropathies. And we also will study in future classes the event potentials like P300 and the cognitive potentials, and all will study in future. So thank you for the class. Why do you check insertion activity in 4 quadrants? That is the you may not be successful all the time. The muscle fibers may be not irritable in one quadrant. They may be irritable in other quadrants. So the pathology may not be uniform in all the. That's why we have to do in 4 quadrants. That is a guideline. That's so that you don't miss anything. Okay. Right then, if there are no other questions, we'll meet next week sometime when we come back with some of the how do you interpret the neuroconduction studies as well as some anomalies in the neuroconductions, like then those anomalies we'll study in the next, and then we'll go on to the disease per se. Okay, then good night. Most of you are already off. This is the AMG class, so this is only sensitization. Please start reading now.